Atria to ventricles, ventricles to the great vessels. Valves prevent movement in reverse. And then the fourth one, regulating blood supply right here. Right? Changes in contraction rate and force match blood delivery to changing metabolic needs. And the more active a tissue is, the more blood it requires. So we're going to have kind of changes so that we can bring blood to the more active tissue. If you think about what happens when you exercise, if you're jogging, you need to bring more blood to the leg muscles. So then you can have more oxygen, more glucose, more ATPs being produced. So we're going to see that you also, when we are working out, dilate the blood vessels leading to your leg muscles. So then you can have more blood flow there. So then you can more efficiently contract. This is how we're able to run marathons. Well, some people are able to run marathons over and over again. So the more active the tissue, the greater the blood supply. And here you can take a look at, where the left side of the heart pumps blood all the way towards the rest of the body. The right side of the heart only pumps it to the lungs. And again, right, because you're pumping blood such a short distance, you don't really need to pressurize it as much. And to make it even make it more understandable, what happens if you pressurize anything? If you pressurize something, it moves fast. If it moves too fast through the capillaries of our lungs, you don't let the red blood cells have time to quietly go through the blood vessels and pick up oxygen and get rid of carbon dioxide. So there's a lot of different factors for why the blood pressure here is so low. All right, the blood pressure in the right heart is so low. One, because we want more blood movement, right? And we want slow blood movement. Now, one other thing we're going to see is that the greater the pressure, the more likely we're going to have some kind of edema, some kind of blood movement and fluid movement out. So low pressure prevents that in the pulmonary capillaries here. So we're going to talk about these coming up, and then I'm going to show you some videos about how the heart contracts, right, and the sequence of the contraction. Again, right, it's a tight fit between where the lungs are and where the heart is. So the lungs on each side are going to border the heart. And I will show you in a second some x-rays, and most of you guys have seen your chest x-rays before, right? And most people see this kind of white blob in the middle, and they kind of assume it's a heart. It is your heart, right? And what happens is that, the heart's thick, right? It's going to be thickly walled, lots of muscle. So x-rays can't get through. Because it can't get through, it appears white on the actual x-ray. Now, it's located in the middle of our thoracic cavity in an area we call the mediastinum, and it's going to be bordered on each side by the lungs. Now take a look at how tight this fit is. Right here, it's okay, we just started. Right, here's the heart right here, here's the lung on each side. Keep in mind, the lungs are going to inflate and deflate 10 to 12 times a minute. So that's, it's inflating and deflating 10 to 12 times a minute. The heart is at least going to beat 60 times a minute. So the heart is contracting, the lungs are inflating and deflating. There's a chance where there's a lot of rubbing and a lot of friction. And a lot of friction can cause lots of pain. So what do we do to prevent it? We have a little bit of tissue that we can use to kind of border the lungs, and then tissue that kind of covers the heart. That's a pericardium, right? So the tissue that borders the heart ensures that as the heart contracts, it doesn't rub on the lungs. As the lungs deflate and inflate, it doesn't rub on the heart. So all of this is happening, and the pericardium is there, so then we can prevent friction. Now, there are times when we can get infections of these, right? So you can have infections of the heart. We call it myocarditis. Sometimes it can cause people to die suddenly, right? Unfortunately, one of my cousins, his son, when he was 11 years old, right? All of a sudden, been healthy his whole life, right? He was sick one day, The next day, he went into cardiac arrest, right? He died because of myocarditis. And he asked me to look at the autopsy review. And what I found out when I read it and talked to, the actual coroner, the medical examiner, was that of all the bad places for him to get that viral infection, he got that infection in the pacemaker, which caused his heart to go into an arrhythmia, right? And without that pacemaker, then all the areas of the heart, they're autorhythmic. They don't get that message to contract, right, from the pacemaker now. So they contract on its own timing. And it caused him to go into arrhythmia, and he tried to do CPR, and it didn't work, and he passed away on the way to the ER. And you can imagine, right? I mean, I remember going to his funeral, and you look at the casket, and you're like, oh my God, it's a small casket. And it kind of made it real. But it does happen in kids, and it does cause, every now and then, kids to die from this sudden kind of illness that you don't think that a kid should die from. So in anatomy of the heart right here, I'm going to talk about the pericardium, and then I'm going to talk about the fibrous skeleton. There's a big difference. Notice none of this is highlighted, right? Why? Because that's the anatomy part. So there's a fibrous pericardium and the visceral. And I want you to think of this as something very similar to when we discuss the brain and the meninges. Right? Remember in the brain and the meninges, you had the dura mater covering the whole external shell, and it's very strong, the dura mater, very thick, very tough. That's the fibrous pericardium on the externalmost aspect right here. Then in the brain, you have the arachnoid mater, kind of that middle layer, right? The middle layer is the parietal pericardium, lining the inner side right here. And then the visceral pericardium is like the pia mater. The pia mater of the brain and the spinal cord, you could not remove it without damaging the brain and the spinal cord. The visceral pericardium is actually part of the heart itself, right? Because it's kind of like entirely connected to the heart wall itself, you can't remove this without actually causing damage to the heart. So these two are continuous. There's a little bit of space between the visceral and the parietal pericardium, and that space is filled with fluid that allows us to resist friction. Now, you can also get infections on here. I remember when I was doing my clinicals and I was working with a cardiologist, and this person was sick, and he's in cardiology, so you know that something was wrong with the heart. But when I tried to listen to his heart, the heart sounds were incredibly distant. Meaning that I'm listening, I'm putting the stethoscope right where the heart should be, and I barely hear any heart sounds. I'm like, okay. Yeah, that's one of those where you kind of flip everything, making sure that, that I'm on the right side, the bell's on the right side. So I listen to the other side, and I'm like, okay, I still can't hear it. And then what happened was, he had pericarditis. And when you have pericarditis, the heart sounds are incredibly muffled. You don't hear it. You actually have to get really close. And my friend, who wanted to be a cardiologist, had one of the new cool stethoscopes, right? The cool ones are one you can actually put on somebody, and they magnify the sound. Kind of cheating, I think, but right? So his actually magnified the sound. His had a button where you can actually record the sound, and then download it to the to the computer and listen. Now this is like 10, 15 years ago. So that technology was like like $3,000-$4,000 for a stethoscope, right? I had a nice stethoscope that was like $800-$900. I was afraid to use it because I was scared to death I would lose it. I can imagine I had an $8,000 stethoscope. I would never bring it to work, right? It'd actually be at home because I'd be so scared to use it. So yes, these things do happen where we do have infections. We have problems that can occur with the heart itself. Now the heart wall right here, and starting from internally right here. So if you look at your heart, you'll notice that it is very, very, very shiny on the inside. is very shiny because it's lined with the same cells that line the inside of your blood vessel. So the inside of your blood vessel, you want something nice and smooth, and we have simple squamous epithelial cells, right? Not something flat, something smooth. Same thing here, right? We call it the endocardium. The endocardium is going to be comprised of simple squamous epithelial cells, allowing us to have nice, smooth movement of blood. The myocardium is this thick layer right there. Now, when we dissect on Monday, the only way we'll be able to tell which side is which, we can guess, but the only way we can actually tell for certain what's your right heart, what's your left side of the heart, is by cutting it into front and back pieces. And in the pig heart, the left and the right sides are very different, just like ours, right? The left side, very thickly walled with lots of myocardium right here. We use that term interchangeably. Myocardium, cardiac muscle. Sometimes if you go look online, they're called cardiac myocytes. So all of those mean the same thing, heart muscle, right? These are the ones that when they die will cause permanent damage. The pericardium out here also contains just smooth, simple squamous epithelial cells, right? And this epicardium is going to be very similar to what we see in the visceral pericardium. Right? It's kind of weird to see how much fat we have here. You're going to see that when we look at the pericardium of the pig, there's a lot of fat in the pericardium, right? So we do have a lot of fat. Sometimes the fat isn't just that you're out of shape. Sometimes that fat is there to protect you as well. Pectinate muscles. Pectinate muscles are found on the, of course I don't have a right atrium wall on this one, right? On the wall of your right atrium. Now, they don't look like they're very noticeable in the model. When we do cut into the atrium, they're very noticeable, right? They're kind of on that muscle wall facing the atrial wall, atrial chamber itself. These pectinate muscles. They're found in the auricles, in the right atrial wall. The Trabecular Karne are the ridges formed by the cardiac muscle. So that's what we see here, the ridges on the other side, right? It means that the cardiac muscle doesn't lay flat, that there are parts of the cardiac muscle that kind of extends outwards into the chamber. And it gives you this ridging effect that we see. That ridging, because the cardiac muscles extend into the chamber, well, that ridging is called the Trabecular Karne. Right? And we'll talk about some of these arteries today, and we'll kind of go through the wireman. So, we get started on that. So we have plenty of time to soak it in, and I'm going to give you open lab time today. So don't freak out. All right?
Actually,
yes.
So with these Trabecular Karne, is it ridged because the ridges allow for more surface area, so you're getting a harder
You're having, right, so you're gonna have the ridges are from all the different branch points that come out, so then you have increased strength, yes.
Okay.
Right? So then instead of just contracting in one place, kind of like your muscle contracts only up and down like this, and that's all it does, now you have a 360-degree contraction. So then you can squeeze things from the bottom, which is what we want, right? So we want to squeeze from the bottom up, because your vessels, your pulmonary trunk, your aorta is on the very top. Your ventricles on the bottom. You need to somehow squeeze from the bottom up, so then you can move blood into the great vessels. Again, we'll talk about some of these, and so the pictures right here, and I'm going to show you some pictures, all right? I'm not going to use pictures on the, on the lab practical. That we have so many models. I'd rather use models that are three-dimensional. So one of the things I will do though is show you some of the pictures that online, because I want you to see just how big some of these coronary arteries are. Some of the vessels that we're going to talk about, like the splenic artery, they look pretty small until you see it in our body. In our body, they're huge, right? The splenic artery, well, you're gonna recycle a lot of red blood cells. So you're gonna need a large artery to carry all that blood in there. And we're gonna go through these, right? The external anatomy as we go through more of the heart. We already kind of did last week, Monday. So keep that in mind. All right, coronary arteries. So we kind of mentioned it before. We have the right coronary artery over here. The right coronary artery is going to give rise to the right marginal branch. And it's going to come backwards and turn into the posterior interventricular artery or posterior descending artery. Again, because most of us are going to be like in the clinical field, I'd rather use the word posterior descending artery. You will not hear posterior interventricular when you're getting your, an echocardiogram done. When you're getting, God forbid, you have to do an MRI in the heart or something, right? So you're not going to hear that. You will hear instead PDA and LAD. We love our acronyms in medicine, right? We really do. Some of the acronyms are ridiculous. They're like 8 letters long. You're like, okay, come on now, right? But they do use those acronyms. Here are these 3 acronyms. PDA, posterior descending, coming right off the right coronary artery in the back, posterior, right? And then LAD, anterior descending, coming off the branch point between the left coronary artery and the circumflex artery. Now, when you take a look at this right here, you will notice that the coronary arteries are immediately found. For some reason, Siri came up and told me what the coronary arteries are, right? So here, the coronary arteries, the opening is called the ostia. We saw the opening for the coronary sinus over here, that little black, red dot right here, right? That's the opening for the coronary sinus. Now, on Monday, we should try to find the opening right above the aortic valve, right? We kind of found some of them yesterday in my other class, right? We found the openings that lead to the right and the left coronary arteries. They're very small, right? They look like little pucker shapes, and they're immediately above the aortic valve. And what happens is this: as blood is pushed into the aorta, you start to distend the aorta. The aorta is like a rubber band. The more you pull it, the more it wants to snap back. So as blood is pushed up into the rubber band, into the aorta, you stretch it and you stretch it. Eventually, as the heart has to relax, you pressurize the aorta so much that the resistance there, all right, and now there's relaxation in the heart, there's not enough forward pressure anymore, right? Now the aorta wants to snap back. As it snaps back, blood starts to move backwards. As the blood moves backwards, it moves back and it's going to seal the aortic valve. Then blood moves into the right and the left coronary arteries. So the coronary arteries are the only arteries that receives blood at rest. At the rest of our heart, right? The diastole of the heart. It's the only organ, the heart, that receives its blood supply when it's at rest. Every other organ, well, if you're going to bring blood to the arm, the only way blood gets brought to the arm is you're contracting the heart and ejecting that blood out. It's in systole. So the only organ that receives blood at rest is the heart itself. It kind of makes sense, right? If the heart's going to be contracting really hard, it's really hard to bring blood through the coronary arteries at that point. There's too much tension in the heart itself. So the blood itself gets ejected up. When the heart muscles relax, blood moves back downwards. As it moves back downwards, then it goes into the right coronary and the left coronary arteries. These are very, very small openings. So when we say that we have to do an angiogram or an angioplasty, right? In angioplasty, you might have a blockage at a coronary artery. So let's say your LAD right here has a little bit of blockage. So somehow we got to get a needle into LAD. That needle has a little drill bit in it. I know, right? So what happens is we actually go through the femoral, then work its way up the abdominal aorta, and then we have to find these little tiny openings, right? Just shortly above the aortic valve. Look for it, and then have a wire that goes through, right? Then find that area that's kind of occluded, and with the little drill bit there, kind of puncture through, right, that occluded vessel. As we puncture through, now we hopefully can resupply, right? And we have the stent that goes in there, kind of reinforces and keeps that area open. That's what we'll see in an angioplasty. Now, bypass graft, right? You'll hear people, it is quite amazing how many people actually brag about some of this. They'll say, oh yeah, I had an angioplasty, I had 8 of them, right? 8 vessels that need to be cleaned up. It's like, okay, I don't know if I'll be bragging about it, but people do. And some people actually, discuss it pretty openly. The left coronary, keep in mind, you don't see the left coronary artery on any of these heart models. You do see it on one of the old ones right there that Shantae has, right? It's old, it's good for certain things. One of the things it's good for is that they show a very small stretch of the left coronary artery, right? Now, on these, what we see is that, oh, mine was missing it. What we see here is LAD coming down and the circumflex. So what it means is that you've already split the vessel, right? The left coronary artery lies below the pulmonary trunk. By the time we usually see it, it has already split in half. It splits into the LAD and the left circumflex artery. Right? You have a left marginal and a right marginal branch. Right? The marginal branch is on the sides, the margin of the actual heart. The cardiac veins, right? Again, keep in mind, arteries bring blood to a region, but they're always connected to the vein, which brings it back, right? So veins always run with the arteries. So we have the great cardiac vein right here that runs with LAD. The great cardiac vein brings deoxygenated blood from your septum, from your left ventricle region. As it brings it back, circles around, and it leads into the coronary sinus. You have the small cardiac vein that runs with right coronary artery. So wherever you see the right coronary artery right here, you see the small cardiac vein. And then you have the middle cardiac vein and the small kind of fuse together, and everything eventually empties into the coronary sinus, right? Again, these veins are one of the rare examples where they don't have the same name. Everywhere else, you'll have a splenic artery, you'll have a splenic vein. A renal artery, a renal vein. Kind of makes it easier. Superior mesenteric artery, superior mesenteric vein. Right? Guys, see how that goes? Radial artery, radial vein. All right? In the heart, it's kind of different. You'll have then great cardiac vein, small cardiac vein, and middle cardiac vein. So just keep in mind that if you remember how they drain and how they're connected, it kind of makes it easier to kind of decide which one is which. And we know LAD is incredibly important, right? If you have occlusions in LAD and have MIs as part of LAD, usually those are your widowmakers, right? And what happens is, well, if it's that important, then the vessel that drains it will be very important as well, with the word great cardiac vein. Right. The chambers, right atrium, left atrium, right ventricle, left ventricle, right? So keep in mind that as we go through this, you will have time to kind of, digest this. I know we're kind of hitting you hard right now, but we will have time to digest it and slow down in a bit, right? Now, you should have a connection between the right and the left atrium. That should be there in utero, right? There's a foramen ovale that we see, and you can see it from the right atrium, and you can see it on the left atrium. The scar tissue that forms is called a fossa ovalis. In utero, well, it's not scar tissue, it's a real opening. that connects the left atrium and the right atrium, right? That opening allows blood to go from the right atrium directly to the left, bypassing the ventricle and the lungs, right? So then, again, there's no oxygen in the lungs. Why bring blood to the lungs? That's our first bypass. The second bypass is whatever blood does get into the right ventricle goes up the pulmonary trunk where you see another scar tissue. And this one's really small. If you look really close between your aorta and your pulmonary trunk, you see some white tissue over here, right? That is your Ligamentum Arteriosus. In utero, it's not scar tissue, it's an actual opening between them. So whatever small amount of blood gets into the right ventricle goes up the pulmonary trunk and goes into the aorta directly, bypassing the pulmonary arteries and the lungs.
So you said it's the
Ligamentum arteriosus.
arteriosus.
Now, we should have a little bit, and it's not uncommon for babies to be born with slight openings of the foramen ovale or the ductus arteriosus, right? That does happen. Usually it resolves by itself, right? And it gives you some kind of minor heart murmur that kids are born with. And we call it a congenital heart murmur. Congenital means you're born with it. That does happen, usually it resolves by itself, right? Usually it doesn't require surgery, even if it doesn't resolve by itself. We just give some medicine and the medication should actually close it off. That's a cool thing about these. Now, if you have a little kind of an opening between your ventricles in the interventricular septum, that requires surgery, right? There's no amount of medicine that will close that off. And not only that, right, what we're gonna see is if there's an opening between these two ventricles, that is automatically a pathology, right? You have to do surgery or else the baby's gonna die from this. Myocardial thickness and function. The thickness of the myocardium varies according to function of each chamber. We're gonna see that the atrials, the left and right atrium, well, those atria are gonna be thinly walled. They're not gonna need to contract with a lot of force. If you think about it, all it has to do is just eject blood to the ventricles, which are underneath. So it doesn't even have to contract with for a lot of distance. It only has to move blood that little bit, and that's it. The ventricular walls are much thicker. They're the main pumps, right? They move blood to the lungs, the right side, and to the rest of the body, the left side. The right ventricular walls are thinner than the left because the distance they have to move is shorter. They only have to go to the lungs, which are really close, right? Which are already nearby. And there's very little resistance to blood flow. We're gonna see resistance to blood flow is really dependent on how open the blood vessel is. The more dilated the blood vessel, the lower the resistance. The easier it is to move that blood, and the less pressurized that blood becomes. So in the lungs, that high oxygen content, because we're breathing, we're healthy, what happens? When we're breathing well, we're healthy, there's a lot of oxygen in the environment, the oxygen content in the lungs increases. That allows you to dilate the pulmonary arteries, which allows you to then easily bring blood into the lungs. The blood then slows down because you don't have to pressurize it. As it slows down, each red blood cell slows down as it goes through, and it picks up more oxygen. Perfect. That's exactly what red blood cells should do, right? Again, oxygen levels here cause vasodilations, therefore decreasing the blood pressure. All right, right ventricular pressure, 15 to 20 millimeters of mercury. All right, much lower than your diastolic blood pressure. So when you think of diastolic blood pressure, we think, oh, what does it measure? And I'll ask you that in chapter 21. What does diastolic blood pressure measure, right? And we're gonna see, if you look it up online, it's actually not easy to find, right? They'll talk about numbers, but you actually have to look things up a little bit closer to understand what diastolic blood pressure measures. The left ventricular walls are thicker because they pump blood throughout the body, where resistance to blood flow is greater. Again, you need to increase the pressure because you're usually working against gravity, right? To move blood into the most important organ of our body, our brain. So again, we're gonna talk about it, and we kind of mentioned it last semester. When we have a stroke, our blood pressure increases. Why does it increase? The high blood pressure is not causing the stroke. Everybody thinks that the high blood pressure, you know, I had somebody walk into the ER at Cook County. When I took his blood pressure, he was 220 over 140. I'm like, okay, I'm messing up, right? There's no way the guy's talking to me, looking good, right? His only complaint was that he was dizzy. He didn't have any kind of, you know, paralysis, did not have loss of sensation on any side. And he wasn't slurring his speech, nothing like that. So I'm talking to him, I'm like, and I'm, you know, taking the blood pressure, 220 over 140. All right, let me try a different cuff, right? Check it again, 220 over 140. At this point, I'm freaking out, right? I'm like, I either don't know what I'm doing, and I'm gonna get yelled at by my attending, or this guy's really, you know, really gonna crash in front of me. So the attending comes in, the head doctor comes in the ER, and he checks it again, 220 over 140, right? And then he asks me, what do we do, right? And that's the thing, what do you do when it's that high? So you would think you would lower the blood pressure because it's dangerously high. In reality, we just watched them. Reason why is this: if you would be having a stroke, that could be the only thing keeping blood moving past that narrow passage. So if you think about it, you have a blood vessel that used to be big, and now there's a clot inside. Now the vessel has shrunk, right? As it shrunk, well, if you have the same blood pressure, very little blood can get through. So the body does the only thing it can at that point. It can't make the blood vessel disappear, or else it never would have happened. It can't increase the diameter at that point, right? So the body does whatever it can, and the only thing it can do is to pressurize blood so that it can rush more blood through that narrowed opening. If it would decrease the blood pressure, less blood would go through that narrowed opening. And now you will make that stroke a lot worse. So that is some of the things that we will discuss here, is that, yeah, you know, in real life circumstances, keep in mind, it's not that the high blood pressure is causing the stroke. The high blood pressure we see and we measure is actually a signal of a stroke, right? Signal is something you see. That's a signal that you are having a stroke at that point, right? For some reason, he didn't have a stroke, right? His blood pressure went down normally, but this guy must have missed his meds for a few weeks. And you see, like, I mean, it's crazy how many people, right, don't even bother taking their meds.
Yeah.
All right. Decreased oxygen in tissues is a sign of an active tissue, right? So just keep in mind, we kind of mentioned it a few times, that decreased oxygen and increased oxygen, whether we're talking about the lungs, whether we're talking about the systemic tissue, has different effects, right? If I have decreased oxygen in the lungs, what happens? Well, it means there's something wrong in the lungs, right? If all of a sudden your lung capacity decreases, or the oxygen in the environment decrease, now there's less oxygen going into your lungs. Well, the area where we don't want to bring blood into that area of the lung that's damaged. So the area where you have less oxygenation, right, starts to constrict. Probably the better example if you get into a car accident and you have a collapsed lung on one side. If you collapsed lung, there's no oxygen moving, there's no gas moving on that side that's collapsed. It's collapsed, right? So what happens? Well, you don't want to bring blood flow to that side because there's no oxygen. So low oxygen in the lungs causes vasoconstriction. So then you can detour the blood to the areas that do have higher oxygen content. Perfect, right? Nobody hopefully gets so unlucky that both sides of their lungs collapse. If you do, that is a life-threatening condition. Usually what happens is one side of the lungs collapse, And usually one lobe collapses. And when it collapses, the other side is usually pretty healthy. So the other side has lots of oxygen, it dilates. So then we can redirect blood flow to the healthy lung. And we can stop blood flow to the unhealthy one. Right. In the systemic tissue, it's completely opposite. Right? Decreased oxygen, seen when you're working out, is a sign of activity. So if it's a sign of activity and you want to keep working out, you dilate when there's decreased oxygen. So it's complete opposite as what we see in the lungs. Take a look at how big that left ventricular wall is compared to the right. All right, so left ventricular wall here, right ventricular wall. Now, if I measure the amount of room, it should be the same though. Right? The chamber size should be the same on each side. The valves. And when we cut into the heart on Monday, we'll notice that it is very different. The two atrioventricular valves are found between the atrias and the ventricles. The tricuspid on the right, the mitral on the left. Those valves are going to be connected to muscles, papillary muscles, that open and close those valves. The semilunar valves, pulmonary and the aortic valves, are only pressure valves. There's no muscles connecting it. There's no chordae tendinate connecting it. They only open and close in response to certain pressure differences. When the cusp of the semilunar valves are filled, the valve is closed. When the cusp are empty, the valve is open. Now the cusp are the cup-like connective tissue that forms these semilunar valves. If you look in there, over here, you can see that there's 3 of them, right, in the pulmonic, and 3 of the cusp on the aortic valve. And they look like miniature cups, each one. They're gonna fill with blood, closing the valves. And that blood sitting on top of it is the pressure we actually have to overcome just to open the aortic and the pulmonic valves. Right, so take a look right here. This is a pretty good picture, right? If you take a look, keep in mind your pulmonary trunk is always anterior. It's the most anterior of our great vessels. The pulmonary trunk then is this one over here, because it's anterior. This is the aorta. This is the aortic valve. Remember when I said that you have these tiny little openings, right, that leads to the coronary arteries. We don't even see it on any of the models here. Those tiny openings are here, opening for the left coronary artery, and this small little one deep inside over here, opening to the right. Right? These small openings are what we're trying to find when we do a balloon angioplasty. You can imagine the skill it takes to try to find it, right? Now the good news is that, you know, your cardiologists have had a lot of practice, and they've probably been working with, you know, their fellowships many, many years with a much more trained doctor, right? Bad news is you might be the one that might have an abnormal, right, anatomy. Again, we tell our kids, we tell everybody that, you know, everybody's different, but when we actually see people that are different, it kind of freaks people out, right? Right, the function of the heart valves, again, just keep in mind, no matter where you see the valve, whether the valve is in a vein, whether the valve is in the heart, all valves prevent backflow. That's a big thing about what valves do. They prevent backflow. So then when we contract a region, blood doesn't spill backwards. Whether we're contracting and that we're at the start of systole, well, if we're just contracting at the very beginning, what happens? Well, there's blood sitting on the aortic valve from the last time you contracted. That caused the aortic valve to close. Now, in order to open it, you gotta create enough pressure, right? Create enough pressure from below so then you can pop the top off and open the aortic valve. But it takes time for you to create that pressure. You can't just think that you're gonna contract it one time and boom, it goes up. It takes time to create that pressure, to create the tension. So as we create that pressure, first thing that happens, to prevent blood from going back into the atrium, we need to close the mitral and the tricuspid. Right? And then eventually we create pressure and pressure from below. Now there's more pressure in the ventricle than in the aorta. Now you can open the aortic valve. Right? So aortic valves and the pulmonic valves are usually closed unless you develop enough pressure to open them up. Go through this and then we'll take a break. All right, route of blood flow through the heart. Now, with this picture, I want you guys to understand